Now, what is the concept basically? So if you look at line A, that is, all patients undergoing surgery experience a reduction in functional status postoperatively, but then finally recover and go over the line of dependency. What about the line B? Now, patient suffers a complication, unfortunately, and then obviously goes below the line of dependency, but never goes above it. So has an incomplete recovery, threatening a long-term independence. So you don't want patient on line B. Now, what about C? C is when patients in the preoperative period undergo prehab. So they are much better placed. So when they are placed where they undergo surgery, they are much better prepared to undergo this major surgery, and they recover very well and better placed to cope in the post-op period. And what about line D? Line D is when patient has undergone prehab in the preoperative period, but unfortunately again have a complication. But because they have undergone prehab in the preoperative period, they recover over the line of dependency, unlike the line B, where the patients have not undergone prehab. So this is the difference what we are looking at. So even if the patients unfortunately have a complication, if they have undergone prehabilitation, they will be better in a position to better cope with the complication and come out well from the surgery. So previously it was all about risk prediction and to explain to the patient and the relatives what are the risks involved. Now it's no longer stops there. We're looking at risk attenuation. So this is where there's this multidisciplinary prehabilitation programs that incorporate comprehensive preoperative risk evaluation needs to be implemented and directed to the patient, especially those at risk. And this risk assessment can be done by CPET, that is cardiopulmonary exercise testing, hand grip test, or 6-minute walk test. Or it can be self-reported by the Duke's Activity Status Index. So it's not only that predict the risk, but then it also tells you what the patient will require in the post-operative period. So it helps you to triage these patients in the post-op. So high-risk patient, you can book an ICU bed, whereas if you need a HDU, that's a high dependency bed, you can book that in advance. So you know what sort of resources you're going to need in the post-operative period for the patient, and importantly, whether the patient should proceed with the surgery. Sometimes the risks are so high that when discussed with the patients and patient's relative, they decide against going in for the surgery, which is also their conscious decision and which should be respected. Now, this is similar to a runner training for an upcoming marathon. We prepare the patient for major surgery with prehab by intervening on modifiable risk factors that are going to influence in the post-operative outcome. So this is what we have predicted the risk, but now what we are doing is we are intervening on the modifiable risk factors so that we decrease the risk. So we attenuate the risk. Coming to a quick this of CPET. This is an established role in the evaluation of perioperative risk in the range of major surgeries. It is obviously an objective method. It allows interrogation of causes of exercise intolerance when exercise capacity is reduced. It provides a global assessment of integrated responses of pulmonary, cardiovascular, hematological, and metabolic system. It can be either done by cycle or the treadmill.